Hello, I am Santosh Varghese, working in the Department of Nephrology, Christian Medical College, Vellore. Welcome to this module on chronic kidney disease. The following outline will be used: a short introduction to what chronic kidney disease is, who are the people who are at risk for getting chronic kidney disease, how does it present clinically, how do we screen for, and general principles of treatment, which will be the bulk of the program. Chronic kidney disease is a huge health burden in India, and the data shows the prevalence varies from as low as 0.7 to as high as 13% in different studies. Unlike other conditions, chronic kidney disease is different in what chronic means. The chronic in chronic kidney disease must mean irreversible rather than a long duration. For example, chronic pulmonary obstructive disease or COPD, you look for how long the patient has had symptoms. In chronic kidney disease, the symptoms may not be of a long duration. Therefore, you must use it to mean irreversible kidney disease rather than long duration. Why did we change from chronic kidney disease to from chronic renal failure to chronic kidney disease? When I was doing my training, we used to say CRF or chronic renal failure. This led to two problems. One, the doctor would be unsure as to who was mild, moderate and severe. I had some of my colleagues writing 0.8 creatinine is normal, 1.5 creatinine is mild renal failure, 2.5 creatinine is moderate renal failure, 3.5 is severe renal failure. So I asked one of them, why do you say mild, moderate and severe? He said, well, it's a little bit elevated, therefore it's mild, a little more elevated is moderate, quite severely elevated, therefore it's severe renal failure. This also caused considerable confusion among patients. For example, I had a patient whose discharge summary said mild renal failure. He looked at me and said, mild renal failure? You mean my kidney is lost? So I had to explain to him that this disease was mild. On the other hand, patients would not know whether the disease was going to be remaining stable or whether it would progress. And therefore the National Kidney Foundation several years ago came up with this nomenclature of chronic kidney disease, where failure is set apart to denote the truly last stage of disease. It also incorporated all chronic diseases under one umbrella because of its potential to cause chronic kidney disease. So why all these fuss? The number of patients who have end-stage kidney disease is growing worldwide. For each person who requires dialysis or transplantation, it's estimated that over 2,000 have some degree of renal dysfunction. And diabetes and hypertension are the two common diseases which contribute to end-stage renal disease and are increasing in incidence and prevalence and are associated with high risk of disease, mainly from cardiovascular disease. The mortality in these patients is over 1,000 times higher than the general population of the same age. And the focus in recent years has been to optimize care during the phase of the disease before the onset of end-stage renal disease. How do we estimate glomerular function? Insulin clearance, radioisotope clearance has been recommended, but they are costly and not easily available. Therefore, we are stuck with using serum creatinine, which is very poor predictor of glomerular filtration rate. It is influenced by a lot of things which we'll come to in another few minutes. The gold standard for determining kidney function is cumbersome. Therefore, we stuck with calculated creatinine clearance to correlate for glomerular filtration rate. Let me show the same thing on this graph. There's glomerular filtration rate and creatinine on the y-axis and time on the x-axis. The dotted line represents the creatinine which is considered normal according to the laboratory. Suppose somebody has got a disease and his glomerular filtration rate is dropping. By the time we are aware of it, or rather we notice the creatinine being abnormal, over 50% of the glomerular filtration rate has already been lost. This is a very commonly used equation, not very accurate, but can be used at the bedside. It is called the Cockcroft and Gault equation and uses age, weight, creatinine and gender. It's important to remember that this is creatinine clearance and the glomerular filtration rate is actually 15% lower because some creatinine is secreted into the tubules and excreted out of the body. This equation is a creatinine clearance value is used for calculating drug doses, which we'll come to later. Let's look at this example. Supposing we have two patients, one a 70-year-old lady who's 45 kilograms and her creatinine is 1.5 milligram per deciliter, and we have a 25-year-old muscular man weighing 85 kilos, creatinine of 5.32 milligram per deciliter. Which of these is likely to alarm us more? Actually, the woman with a creatinine of 1.5 has a lower glomerular filtration rate than the man with a creatinine of 5.32, highlighting that creatinine values by themselves don't mean anything and we must estimate the glomerular filtration rate always. The factors that increase or decrease the creatinine are given below, of which kidney disease is obvious, but drugs like trimethoprim or sulfamethoxazole is also to be kept in mind for increasing the creatinine. On the other hand, a reduced muscle mass or malnutrition can cause a decrease in creatinine and may falsely give us the impression that the patient's kidney function is reasonably okay. If creatinine is so bad, why not use urea? However, urea is elevated and reduced by simple things like hydration, starvation, gut bleeds, protein intake at pregnancy, etc. And therefore it varies even more and therefore cannot be used as a marker of renal function. This estimation of glomerular filtration rate has become like an epidemic, and medical practitioners all over the world have suddenly been seeing that there's mild chronic kidney disease everywhere. It's important to know that it's not been validated for our population. It's not valid for extremes of age, obesity, severe malnutrition, low protein diets, paraplegic, amputees, etc. Also, it's not useful for rapidly changing glomerular renal function, especially like patients in the ICU who are sick with acute kidney injury. However, since it's the best we've got to live with it. Specifically looking at the definition of chronic kidney disease, if you know the duration, it's 3 months or more, defined by structural or functional abnormalities of the kidney as manifested by pathological abnormalities or markers of kidney damage with blood or urine or imaging but not hypertension, or glomerular filtration rate remains less than 60 ml for 3 months with or without kidney damage. What do I mean? If suppose a patient has cysts in the kidney, or he's got scarring on ultrasound, or his kidney sizes are small, these constitute irreversible damage and therefore this patient has got chronic kidney disease. If they've got stones which don't go away, is chronic kidney disease. Renal biopsy showing a lesion which doesn't disappear in 3 months is chronic kidney disease. On the other hand, if somebody's got proteinuria or microalbuminuria by the way is now called moderately elevated albuminuria, or hematuria or CAS lasting for more than 3 months, is chronic kidney disease. This is the list of the stages of chronic kidney disease. More than 90 is 1, 60 to 89 is 2, 3A is 45 to 59, 3B is 30 to 44, and so on. Please look at the different color codings. The disease is most severe in patients who've got increased albuminuria. This Titanic iceberg model is very useful when looking at chronic kidney disease. We often think of only the severe kidney disease patients. However, it's important to remember that for what we see on the outside, there's a lot that's hidden, and especially more so the at-risk group, which we must address very carefully. So, who are those at risk for developing chronic kidney disease? By diagnosis, there's a small list given here, of which diabetes and hypertension are the most important but by no means exclusive. Other conditions like systemic infections, autoimmune diseases, etc. are very important. The Chronic Kidney Disease Registry of India, which is pan-India but voluntary reporting of chronic kidney disease etiologies, showed that diabetic nephropathy was about 31.2 and hypertension was about 12.9. Together, they constitute more than 44% of chronic kidney disease in India, which makes it very significant. The prevalence of diabetes, as we know, is expected to increase with time, and soon India will become the world capital in diabetes. Hypertension is also very prevalent and can be considered the most common chronic disease in India, and the prevalence is 20 to 40% in urban and 12 to 17% in rural, and in both populations it is increasing rapidly, and it's estimated by the year 2025 we'll have 214 million hypertensives in India, affecting both males and females equally. As we know, the lifespan or the life expectancy in Indians has been steadily increasing and is expected to reach 65 and it's crossed 65 and a half years a few years ago. It may go up further with time. Therefore, logic tells us that longevity, increased incidence of diabetes, increased incidence of hypertension will definitely lead to an increased prevalence of chronic kidney disease in our country and becomes a big burden. To add to all that we know is the entity of chronic kidney disease of undeterminate origin or CKDU, predominantly affecting certain rural populations, where we find a chronic kidney disease prevalence higher than expected in the rest of the country. These patients do not have hypertension, hardly any proteinuria, and when biopsy it shows chronic interstitial nephritis. They are seen in those with manual labor, probably with NSAID intake and low water intake. There may be a lot of pesticides, heavy metals, etc. implicated, but the jury is still out as to what's responsible. Similar conditions are also seen in Mexico and certain parts of Sri Lanka. If we were to consider the large Sikh study, we'd find that nearly 6% of India has chronic kidney disease stages 3 or above, which is a huge number. If we were to say that nephrologists should focus on advanced kidney disease and look at only stage 4 or 5, that is itself over 2 crore Indians who are affected by chronic kidney disease stages 4 or 5, and that would be about 21,000 patients per nephrologist. If we were to see them once a day, we would be seeing once a month, we would be seeing 707 patients a day, or even if you were to see them only once in 3 months, it would be still over 230 patients a day, which makes it impossible for chronic kidney disease, even advanced stages, to be managed only by nephrologists and requires evaluation and medical management by all medical practitioners. How does chronic kidney disease present clinically? The most common presentation is asymptomatic. If we look at the urine, we'd find proteinuria or hematuria. They could also present with nephritic or nephrotic syndromes, hypertension, especially if they are less than 40 years, unexplained anemia or uremic emergencies, and incidental elevation of creatinine. My DM dissertation was on looking at chronic kidney disease stage 5 and what happened to them before they came to us. And we found that in more than 50% of patients, the first time they went to the hospital, they were told to have a glomerular filtration rate less than 15, which is alarming statistics for our country, knowing that most patients do not have any awareness of their chronic kidney disease earlier stages. And we know that renal disease is progressive once the GFR falls less than 25%, and therefore early detection is crucial to prevent further injury and progression. Chronic kidney disease, as I said, is often silent, and assessment relies on laboratory testing and imaging, but a good history with review of systems and existence of chronic kidney diseases like diabetes and hypertension, medication review, and past and family history of kidney disease are crucial. Blood pressure measurement is essential. We must not neglect it. The history of which we must ask for are polyuria and nocturia. Nocturia is more than half the daytime void at night, not just increased frequency. Intake of analgesics, local herbs are again important history for etiologies. Past medical history of hypertension, diabetes, family history of kidney disease and diabetes, smoking or other important symptoms of history we must ask for. Whom should we screen? Hypertensives, diabetics, those who have proteinuria, hematuria, relatives of kidney disease, we must screen. However, in the community, I would recommend that we screen all patients at least once because a lot of kidney disease is hidden and unknown. What should we do? We must evaluate them at least once and then look for potential reversible causes. We check for the creatinine, estimate GFR in all patients. I cannot say this enough. We must estimate the glomerular filtration rate in everyone, knowing that it is inaccurate, but we must still do it. Check blood pressure in all our patients, and in those who need it, look for ultrasound to look at the size, echogenicity, scar and obstruction. The urine is very simple. It's like interviewing the kidney. Dipstick 24 hours if possible, or a urine protein by creatinine ratio, which is an approximate estimate. And microscopy if the dip is positive for leukocytes or blood, for RBCs, WBCs and CAS. Microalbuminuria or moderate to elevated albuminuria, especially for diabetics and hypertensives, a simple urine dipstick is enough. Now coming to the core of the presentation is on general principles of treatment. Can we slow the progression of chronic kidney disease? We must ask ourselves, does the patient meet the definition of chronic kidney disease? If no, we must reduce the risk factors. If yes, we must determine the stage, determine the underlying cause, look for risk factors of progression and look for comorbidities. We must do a biopsy for some of them if we don't know what the cause is, especially if they are proteinuric and especially if the proteinuria is high, or the systemic illness, autoimmune disease going on, or if the kidney disease is rapidly worsening in front of our eyes. This may show what the etiology is, and we can institute specific therapy to retard the renal illness and salvage the kidney. So what are we trying to do? On the x-axis we have time. On the red line is a demarcation for chronic kidney disease stage 5. On the y-axis we have glomerular filtration rate. Supposing somebody has got chronic kidney disease and the GFR is dropping and presents to us, left untreated, it may do one of two things. It may rapidly worsen and go faster than the previous rate of progression, or it may progress at the same stage. What we are trying to do is to slow down the disease to the extent that throughout his entire lifespan, he will not require a dialysis or transplantation. Much better if we can arrest the kidney disease and keep the creatinine stable at the same position throughout his life. Occasionally in some diseases we are able to reverse the disease and go back to being healthy and normal. So coming to management, conservative, wherein is control of risk factors which are modifiable or non-modifiable, or renal replacement therapy, which is dialysis and transplantation. Why does chronic kidney disease progress? There are a lot of reasons. The most important is that the remaining nephrons are trying to adapt and manage the function for the whole body. There are a lot of contributing factors like hypertension, proteinuria, etc. So the increased glomerular pressure happens in the remaining nephrons, which hypertrophy and sclerose and drop out. Small glomerular filtration rate fluctuations are common, and that itself is not indicative of progression. Supposing we have a creatinine which increases, we need to repeat and make sure it's not increasing rapidly. Therefore, the things to worry about are a drop in GFR of more than or equal to 25% from the baseline, or a rapid progression, that is more than 5 ml per year. If there's a decline faster than expected, these patients warrant a referral to the nephrologist for evaluation as to why it's progressing. There are a lot of reasons why CKD progresses. The most important are the cause of chronic kidney disease, the level of glomerular filtration rate at the time we saw them, and the level of albuminuria. hypertension and other things, ongoing exposure to nephrotoxic agents are other important agents. The risk prediction models are yet to be completely validated in India. This diagram shows a lot of risk factors and markers of progressive kidney disease. Apart from age, race and gender, which we try to modify, the rest are all modifiable, and therefore there is a potential for reducing the progression of chronic kidney disease. These are the modifiable risk factors. The values are not important because they change with time, but they equal cardiovascular disease protection. At each stage, we must do certain things. The most important thing when we see the patient is to diagnose and treat comorbid conditions and try to slow the progression, reduce the risk of cardiovascular disease. Then, as the disease advances, we must estimate the progression, treat complications, and in advanced disease, prepare and do renal replacement therapy when required. Coming to each of these, lifestyle. When you compare obesity in chronic kidney disease versus intentional weight loss, it is shown that reduction in 3.67 BMI reduces proteinuria, reduces blood pressure, and decrease in glomerular filtration rate. There is no decrease in the glomerular filtration rate, showing that is advantageous. Exercise. There is a decrease in the exercise tolerance and maximum exercise capacity in patients with chronic kidney disease, and is about half to 3/4 compared to healthy persons. Therefore, earlier people used to say that you shouldn't exercise because it can cause reduction in the renal blood flow and glomerular filtration rate and increase proteinuria, causing chronic kidney disease progression. However, it's now known the beneficial effects are much better, and they increase exercise tolerance, improve glucose and lipid metabolism, decrease inflammation, decrease arterial stiffness. Therefore, mild to moderate strength aerobic exercises for about half to 1 hour, 2 to 3 days a week is very advisable. Alcohol has got a lot of positive and negative effects, but it says that more than 2 drinks a day would increase the risk of kidney disease, and therefore would we avoid that. Smoking is very dangerous because it doubles the rate of progression, especially in diabetics, and can cause other things like hypertension, tachycardia, catecholamine release, etc. And therefore, we must stop smoking, and the effect is seen after 5 years of quitting. Therefore, the earlier the better. There is various recommendations for management of hypertension, including weight reduction, diet adherence, sodium restriction, physical activity recommended by the JNC classes. Coming to salt, as low as possible is what we would suggest. Less than 2 grams a day of sodium would be very good to reduce proteinuria, hypertension, and possibly progression of chronic kidney disease. Processed or restaurant foods must be reduced, and salt used in regular cooking is allowed, but no added salt. And salty foods like pickles, papads, salt fish, etc. must be avoided. A word of caution about low sodium salts. Low sodium salts contain large amounts of potassium chloride and therefore must be avoided in chronic kidney disease patients. That brings me to potassium in chronic kidney disease patients. By and large, they must be avoided, and high potassium containing foods like fruits, nuts, juices, tender coconut water must be avoided. Fruits that can be eaten about 100 grams a day would be apples, papayas, guavas, pineapples. There are a few more, but these 4 is what we would tell our patients. High potassium on blood works would necessitate leaching of vegetables, that is boiling them and throwing away the water before cooking. This must be practiced especially in green leafy vegetables. In obese patients and diabetics, 30 calories per day, and the others 35 calories per day, with less contribution from fat. And complex carbohydrates must be used rather than simple carbohydrates. Sago is a good source, and 1 gram of carbohydrate gives about 4 calories of energy, and 6 servings are advised per day. There is a table I've shown in this presentation, but various tables are available freely which we can look at. Now coming to protein, which I must spend a little bit of time in describing. There is a general understanding that chronic kidney disease patients must be made to restrict protein in their diet. Is this true? The Indian Council of Medical Research did a protein survey of normal urban Indians in several cities, as is shown in the slide, and is found that 9 out of 10 persons, that is over 90%, are taking inadequate amounts of protein. That is, people like you and I are taking less protein than is actually required by an adult Indian. This is very close to what is recommended for chronic kidney disease patients in general, and therefore no protein restriction is usually necessary. There are some tribes who have their diet consisting of very high amounts of meat. For them, a protein restriction can be advised. The rest of the Indians, especially those who take less protein habitually, must not have restriction of protein. The dietary protein should be of high biological value, and vegetable proteins are better than animal proteins in general. Good sources of protein are soy protein and whey proteins, egg whites, and whey protein has the advantage of being low in phosphate. Red meat has got high phosphate and fat generally, unless they're lean meat, and therefore are avoided. Protein content of certain foods are listed here. Pulses have about 10 grams of protein per 100 grams and are very useful. Protein supplements are commercially available and can be given to those who are malnourished. I would like to say something about malnutrition here. Many patients go to indigenous practitioners who tell them to be on protein restricted diet, and their creatinine comes down appreciably. Everyone is happy thinking the kidney disease is reduced. However, it's because of malnutrition, because creatinine, as you know, is from muscle, and creatinine is a derivative of creatine, and therefore the decrease in the creatinine is a result of malnutrition rather than kidney disease. Now they've got one more problem on top of chronic kidney disease, that's malnutrition. Therefore, to underline again, protein restriction is not advisable for average Indian patients. This is one list of the nutritive value of Indian foodstuffs. Various lists are available which can be referred to. So the bottom line is the diet should be normal for most people, diabetic diet in diabetics, plus salt restriction, that is, use food only in cooking. Salt is avoided in all other forms, and you must avoid high potassium containing foods except for apples, papayas, guavas, pineapples. Some patients require leaching. Salty foods and salt substitutes are to be avoided. Coming to hypertension, there's a lot of controversy about the blood pressure targets. Just to give a brief overview, if there are patients are proteinuric, less than 130, less than 80, blood pressure is preferred, and in those who are non-proteinuric, less than 140, less than 90 are probably enough. There is various studies, and the meta-analysis actually shows benefit of control of blood pressure, especially in those of proteinuria. This study, published in New England Journal of Medicine 2008, looked at intensive treatment of diabetics with strict control of blood sugars, lipids, triglycerides, and blood pressure with RAS blockade, and also gave them aspirin, showed a benefit as compared to conservative therapy. The ACCORD study showed benefit only in reduction of stroke. Therefore, we don't know exactly what targets we should follow. maybe less than 130, less than 80 is a good idea for all patients. There was a study called the SPRINT study where they said systolic blood pressure less than 120 may be better. This is what it showed, comparing 120 systolic versus 140, and these patients who had the primary outcome was myocardial infarctions, coronary syndrome, stroke, heart failure, or death from cardiovascular causes was lower in those who had systolic blood pressure less than 120. There is a proposal to study the same thing in India as part of the Indian chronic kidney disease study, and we will probably know the answer after a while. What drugs would we use in those who have proteinuria, ACE inhibitors, or angiotensin converting enzyme, angiotensin receptor blockers would be beneficial. It's very important to have a run-in period with weekly creatinines for a few weeks. Look for hyperkalemia or an increase in creatinine more than 20 to 30%. Combining the two do not have any added benefit in reducing progression. There were two large trials which showed that combining ACE inhibitors and ARBs showed increased hyperkalemia and acute kidney injury without any benefit in the kidney or the heart. But it must be remembered that the study was done in elderly Caucasians at maximal doses of both drugs. This is not how we would normally prescribe a drug. We would give them the low doses and gradually titrate the drug to maximum tolerated and then add the second drug. Therefore, if the patients who have proteinuria persisting beyond the use of one drug, we could add the next drug, but a run-in period is essential. In elderly, we must be cautious and gradual escalation with watching out for acute kidney injury, electrolyte imbalance, hypertension, and side effects must be done. Coming to blood sugar control, as chronic kidney disease progresses, increased peritubular insulin uptake, but at GFR less than 20 ml, there is reduced insulin clearance and increased half-life of insulin and reduction or no requirement of insulin in several diabetics, and therefore they are at risk for hypoglycemia. Which drugs can we use? Sulfonylureas and metabolites. The clearance depends on renal function, therefore first generation sulfonylureas must be avoided. However, glipizide is a short-acting drug and can be used very safely. Gliclazide also has inactive metabolites which can be used. Drugs like glimepiride, glyburide, or glibenclamide have longer half-lives and must be avoided. Drugs like alpha-glucosidase inhibitors can cause prolonged hypoglycemia, should be used cautiously. Repaglinide is safe as most of it is metabolized in the liver. The new DPP4 inhibitors, some of them have got very little renal metabolism like teneligliptin and linagliptin. These can be probably used safest of all. Thiazolidine diones have risk of edema formation and congestive heart failure, especially those who have got pre-existing heart failure, and therefore must be avoided. But we can use pioglitazone in smaller doses safely. Metformin can be used in early chronic kidney disease safely and in stable patients. We must avoid in patients whose GFR is less than 30 ml, although the new data is showing that it's probably safer in these patients as well. So what targets would we use? We would target less than 7%, but in those at risk of hypoglycemia, more than 7% is also alright. So reasonable blood sugar control is sufficient. Patients with chronic kidney disease are at increased risk of AKI. We must avoid nephrotoxic agents, especially NSAIDs. We prefer to use paracetamol or tramadol in these patients. Aminoglycosides must be avoided unless absolutely essential, and lipid formulations of amphotericin are preferred over conventional amphotericin. Contrast-induced nephropathy is common, and therefore lowest possible dose and isoosmolar or low osmolar contrast media is used. N-acetylcysteine is not useful, although earlier studies did seem to suggest its usefulness. There is a new understanding about arterial versus venous contrast use. It was assumed that both were equal, but new data is shown us that arterial contrast, like in a coronary angiography, is what causes contrast-induced nephropathy, and not the venous contrast used in a CT pulmonary angiogram or a CT abdomen with contrast. In all patients, we must use volume expansion, and you must monitor the creatinine 48 to 96 hours after the exposure. Gadolinium-based contrast media does not cause acute kidney injury or contrast nephropathy, but I must say it here because it can cause nephrogenic systemic fibrosis in some patients, is untreatable and sometimes fatal. It occurs in a very small proportion of patients, but because we do not know when the exposure occurs, the risk is high in patients of less than 15 ml GFR, and therefore we must avoid. Between the risk of nephrogenic systemic fibrosis due to gadolinium and a contrast acute kidney injury due to a contrast, especially if it's intravenous contrast, we would choose contrast-induced acute kidney injury any day. In all patients, we must observe sick day rules and tell the patients to stop certain drugs, especially if they are seriously ill or dehydrated, for increased risk of AKI. These include ACE inhibitors, ARBs, aldosterone inhibitors, direct renin inhibitors, diuretics, NSAIDs, metformin, and so on. Of these ACE inhibitors, ARBs, whenever we prescribe it to patients with chronic kidney disease, we must tell them stop if they've got severe dehydration or diarrhea and restart when the illness settles. Now coming to lipid lowering therapy. After a lot of angst around the world, the KDIGO have come up with guidelines on how to manage lipids in patients with chronic kidney disease. It's recommended that patients are screened at initial visit only with no follow-up tests. No longer is LDL value used for deciding the treatment per se. In fact, in resource post settings, we could avoid testing the lipid profile entirely. What do? Because more than 50 years of age and chronic kidney disease confers the risk of coronary death or non-fatal MI to our patients, is advisable to give them pharmacological therapy in all patients. As CKD, that is GFR less than 60, and age more than 50, give everybody pharmacological therapy. Less than 49, we give it only for those who are at risk, like diabetes, prior stroke, known risk of coronary death or myocardial infarction, or known coronary disease, and probably start the therapy when they become 50 years of age. Which drugs would we give? The safest are atorvastatin and possibly rosuvastatin, although we need to reduce the dose a bit in advanced chronic kidney disease, not more than 10 milligrams. Triglycerides should be managed by diet modification, weight reduction, increased activity, reduced alcohol, and fish oils. In those who are above 1000 mg per deciliter, we can consider fibric acid derivatives with dose adjustment for renal function. And concomitant therapy of fibric acid derivative plus a statin is increased risk of toxicity and therefore is not recommended in chronic kidney disease. Which drugs would we give? Some drugs are safe, some drugs are meant to be avoided because of their propensity for harm, especially in advanced chronic kidney disease. The other important thing to consider are drug dosing in chronic kidney disease. We must look at absorption, distribution, protein binding, and especially renal excretion. Most clearances of drugs are primarily by filtration, and therefore when glomerular filtration is impaired by chronic kidney disease, we must look at what the clearance is and dose adjust them. How do we set about it? We will calculate the creatinine clearance by the Cockcroft-Gault equation. Choose the least nephrotoxic drugs. If we can't, and if possible, we monitor renal function or do therapeutic drug monitoring, which is not widely available. A loading dose is given as for normal renal function, and therefore thereafter the dose is reduced for maintenance. There are a lot of drugs that cause renal injury. I have listed a few. Pre-renal injury is from ACE inhibitors, ARBs, diuretics, NSAIDs, and radiocontrast. acute tubular necrosis by a lot of other drugs. Acute interstitial nephritis, apart from some of the drugs I said, are the antiviral agents like acyclovir and indinavir. One word about proton pump inhibitors, which are commonly used, can cause allergic interstitial nephritis and must be used in caution, especially with data now coming up that can cause chronic kidney disease. Thrombotic microangiopathy is a rare but disastrous kidney disease which can be caused by some drugs. Some drugs can cause cholesterol emboli or glomerular injury by their direct action. Many drugs without manifesting an acute injury can cause chronic kidney disease, of which the most important for us is the use of chronic non-steroidal anti-inflammatory drugs. We cannot stress that we must avoid its chronic use and try to substitute with paracetamol or tramadol or other similar drugs. Therefore, when we prescribe a drug for a patient, refer before prescribing to see whether dose adjustment is necessary. It's also good to know if dose adjustment is not necessary for some drugs. For example, antibiotics like ceftriaxone, azithromycin, etc., cloxacillin do not require dose modification, whereas other drugs like amoxicillin, augmentin, ciprofloxacin, and etc. require them. Coming to management, evaluation and management of some of the complications. Anemia, we should check the hemoglobin at least once a year in those of stage 3, 6 months in stage 4, and every 3 months stage 5. And there are various tests that we can do, including ferritin, transferrin saturation, B12 and folate levels where indicated. If we give them oral iron, 200 milligrams of elemental iron is necessary per day. We should remember that average tablets contain 65 milligrams of elemental iron, therefore 3 tablets are usually necessary. For those who require higher dose, IV iron sucrose or carboxymaltose, a cumulative dose of 1000 mg is recommended. Therefore, transferrin saturation and ferritin monitoring every 3 months is usually enough. What about usage of drugs like erythropoietin? We do not start them if the hemoglobin is more than or equal to 10 and use them in caution in those who have active malignancy or past strokes. So less than 10, we would start the drugs slowly and escalate the drug dose. Do not allow the hemoglobin to rise more than 11.5 and specifically not more than 12 or 13. More than 13 is dangerous and can cause complications and heart disease by itself. The doses are given below. We must start at a low dose. The 3 available drugs, erythropoietin, alpha beta, darbepoetin and sera. The lower the dose, the better, except that they can cause thromboembolism or seizures, hypertension and cardiovascular disease. Monitor them monthly in the initiation phase and thereafter 3 monthly hemoglobin testing is enough. If there is no increase in hemoglobin after appropriate weight-based dosing, you must refer them for evaluation. Initially, adjuvants like androgens, vitamin C, E, etc. were recommended, but now is not shown to be useful and therefore not to be given. Transfusions are avoided because if these patients are going for transplant in the future, there will be allosensitization, except in their hemoglobinopathies, bone marrow failure, ESA resistance, or urgent transfusions like somebody is bleeding or preoperatively. Bone and mineral density biochemistry testing must begin in CKD stage 5 using calcium phosphorus, PTH and alkaline phosphatase. Monitoring every 3 months is usually enough. PTH can be checked annually and that's probably enough. Except in advanced stages where 3 to 6 monthly testing of PTH is probably necessary. A baseline vitamin D, if available, followed by annual testing is recommended. There is a suggestion that if vitamin D testing is not possible, we can give them monthly vitamin D for 6 months to nearly all our patients. If possible, look for vascular calcification on lateral abdominal x-rays and echocardiography. Bone biopsy, bone mineral density and all are not available or advised. In general, calcium must be kept on a little lower limit of normal, phosphorus must be kept low, and PTH must be kept higher than expected, especially in advanced stages. The dietary restriction is advised, but not at the cost of malnutrition. You must reduce calcitriol or stop in those who have hyperphosphatemia and use phosphate binders, where non-calcium binders like lanthanum and sevelamer are advisable compared to calcium carbonate or calcium acetate just before the food for the best effectiveness. Aluminum containing phosphate binders are not to be used for fear of toxicity except in those who are severely hyperphosphatemic, where you can give it for a maximum of 8 to 12 weeks. The lower the duration, the better. If PTH is rising despite phosphate correction, we may need to give them calcitriol or vitamin D3 analogs or alpha calcidol, and the lower the dose, the better. Alternate day may be enough. In some patients who've got hyperparathyroidism and hypercalcemia, drugs like cinacalcet may be necessary, but these are probably best left to experts. There is metabolic acidosis in most patients, and therefore it is advisable to give them sodium bicarbonate to target a normal or near normal value. The dose is 0.5 to 1 milliequivalent per kg per day, and this has the benefit of slowing the progression of chronic kidney disease, improving bone health, and improving nutrition. There is a lot of debate about hyperuricemia and the treatment. It is known that uric acid rises, but it is not known that reduction is useful. And therefore, in patients with gout, we need to reduce the uric acid to less than 6. In older patients, 7, and asymptomatic patients, probably 9 is enough. But this is all conjecture and we do not have data for this. All patients with chronic kidney disease are at high risk for cardiovascular disease, and antiplatelet agents may be given, and is a risk versus benefit balance. There is no clear advantage of treating all patients that has been proven. All patients must be monitored for hyperkalemia. When you look at newer tests like BNP and NT-proBNP levels, these are inaccurate in patients with eGFR less than 60 and therefore must be interpreted with caution, as is troponins in the diagnosis of acute coronary syndrome. All patients with chronic kidney disease must be evaluated at least annually, examined for peripheral vascular disease. When do we refer these patients to nephrology services? If there is significant albuminuria, proteinuria, microscopic hematuria, or RBC CAS that are sustained, persistent electrolyte abnormalities, recurrent or extensive stone disease, hereditary kidney disease, they must be referred. Subsequently, they can be followed up by the primary physician and referred when there is acute kidney injury or an abrupt sustained fall in the GFR, or if the kidney disease is progressing, especially when it is less than 30 ml per minute. In these patients, we would ask them to follow up monthly with a primary doctor with periodic nephrology review. If the blood pressure is refractory to control despite 4 or more drugs, they must be referred, and timely referral for planning for renal replacement therapy, where we can institute multidisciplinary care with counseling, education, and making of an access and discussion about transplantation. So by and large, it's a partnership between the primary care physician who does the screening, diagnosis and treatment, and the nephrologist who advises about the management and thereafter follows the patient periodically and plans pre-dialysis care. The preparation for renal replacement therapy begins with education about the different dialysis modalities available and transplantation. Support and counseling of the patient and family are crucial. Surgical creation of a dialysis access and discussion about the potential live donor must go hand in hand and reasonably early in the disease. Vaccination of against hepatitis B must begin early in the disease with a double dose compared to normal individuals monthly for 3 months and booster another 3 months later. And if possible, look for anti-HBs levels for a booster if they haven't attained target levels. Pneumococcal vaccine has also been recommended, although I have personal doubts about its usefulness. Coming to renal replacement therapy, It consists of hemodialysis, peritoneal dialysis, and transplantation. As is nearly universally known, uremic symptoms, persistent hyperkalemia, fluid overload, severe acidosis, platelet dysfunction, encephalopathy, pericarditis are usually indications to start dialysis. There is no indication to start dialysis based on a creatinine number, but at estimated GFR levels less than 8 or 10, most people are likely to start rather than wait for a crash start. This is a picture depicting hemodialysis wherein the blood leaves the body, comes through the dialyzer where the exchange happens and good and bad electrolytes are exchanged for each other and returns back to the blood. This is a similar picture in which the membrane is shown, showing the toxins going across from the blood into the dialysate. The movements are by diffusion from a higher concentration to a lower concentration, and osmosis where the water moves across semipermeable membrane and drags toxins, and ultrafiltration where a large amount of water is removed when the urine output is low based on the hydrostatic gradient. However, it must be remembered that these must be done periodically and cannot be avoided. The schedule cannot be altered. They all require arteriovenous connections where we prefer a fistula to any other for access, although we may need to use a graft in some patients. This is a picture of a arteriovenous fistula that is being used to take blood out of the body and return the blood back to the body. The other modality of dialysis is peritoneal dialysis, which can be done at home and requires a peritoneal dialysis catheter to be placed in the peritoneum where fluid exchange happens constantly as long as the fluid is in the abdomen. This fluid is removed and new fluid is replenished periodically. This is a similar picture showing the exit site of the catheter where the catheter is coming out of the body. There are two types of peritoneal dialysis. One is the continuous ambulatory peritoneal dialysis where fluid is kept a while and periodic exchanges happen, or the automated exchanges which happen either at night or night and the day where the cycler performs the exchanges and allows the body to continuously remove the toxins just like the native kidneys do. This table compares hemodialysis to peritoneal dialysis. Modality to modality with respect to time, hemodialysis is more efficient, but overall because peritoneal dialysis is done round the clock, there's not much difference in the efficacy in the two. There are 2 to 3 days between the treatments in hemodialysis, and peritoneal dialysis must be done several times a day. Hemodialysis by and large requires hospital visits unless home hemodialysis is done, whereas peritoneal dialysis is done usually at home. Hemodialysis requires a vascular access. Peritoneal dialysis requires an intact peritoneal cavity. Careful compliance to diet and fluid required for hemodialysis because the dialysis happens only episodically. Whereas peritoneal dialysis, by and large, a little less restriction can also be tolerated by the modality. The fluid removal is intermittent, therefore can sometimes cause symptoms and hypotension. The fluid removal is very slow and usually patients are asymptomatic. If there is a catheter, there can be a catheter-related infection in hemodialysis patients, whereas patients with peritoneal dialysis are at a slightly increased risk of peritonitis or catheter-related infections. Patients with hemodialysis are dependent on others to take them to the hospital and accompany them, whereas peritoneal dialysis can be done at home and the patients can do it by themselves. This is a picture of kidney transplantation in which the donor's kidney is removed and anastomosed in the right iliac fossa or the left iliac fossa of the patient, anastomosing them to the iliac vessels. All patients with chronic kidney disease are usually candidates for transplantation except with those with active malignancy, severe heart or aortic vascular disease or ongoing inflammation, severe neuropsychiatric disorder or ongoing infections. Extremes of age, overt HIV infections, active hepatitis, AB incompatibility are no longer considered contraindications, as are presence of anti-donor antibodies. These patients can be treated and taken up. The donors can be a deceased donor, either a heart-beating or a non-heart-beating donor, or living related donor from a near relative as allowed by the law, grandparents, parents, siblings, children, or spouse. Living unrelated donor, such from an altruistic like a friend or a swap transplant, a pair kidney exchange, can be done with governmental permission. It's also important for us to consider avoidance of renal replacement therapy when the finances are usually borne by the individual or the family, and affordability must be discussed a priori with the patients. Also, goals of care must be discussed with those who are debilitated and in a bedridden state or terminal malignancy by offering them symptom relief, pain management, psychological and spiritual care. So, to conclude, what can we do? We must identify the at-risk population for chronic kidney disease. All our patients must be screened for chronic kidney disease. Diabetics and hypertensives must have their blood pressure and blood sugar strictly controlled. All proteinuric patients must be prescribed ACE inhibitors or ARBs. Complications must be managed appropriately in consultation with the local physician, and early planning of renal replacement therapy, at which time the patient must be referred. Thank you very much for your patient listening.